COVID spreads all over the world, according to CDC, suicide attempts have been increased during pandemic. Nearly 400 million of people suffer depression, which is more than cancer and heart disease. According to WHO, World Health Organization, nearly 800,000 people die from suicide. Recently, a systemic review published by the Nature concluded that depression and anxiety are highly prevalent among students. Today, we are so lucky and honored to have Dr. Jerry Rosenbaum from Harvard here at Channel 1 TV to shed more light on innovative approach on mental health. Dr. Jerry Rosenbaum, psychiatrist in chief at the MGH and professor of psychiatry at Harvard Medical School, is recognized as one of the world's foremost authorities on mood and anxiety disorders. His research contributions include extensive leadership in the design and conduct of clinical trials of new therapies, the design and implementation of trials to develop innovative treatments for major depression, treatment-resistant depression, and panic disorder. Dr. Rosenbaum has authored more than 400 original articles and reviews and has published 12 books. He currently serves on 12 editorial boards of professional journals or newsletters. At MGH, he directs a department of over 600 clinicians, researchers, and trainees, which has been ranked by US News and World Report as the #1 department of psychiatry in the United States for the past 12 years in a row. Also at MGH, the largest hospital-based research institution in the world. Dr. Jerry Rosenbaum, the director of Mass General Hospital's Center for Anxiety and Traumatic Stress Disorder and MGH New Center for Neuroscience of Psychedelics. Dr. Rosenbaum, I'm so honored and privileged for this interview. Thank you so much for your time and accepting our invitation.
Thank you, Nagar. It is a pleasure to be here with you and to have a chance to have this conversation.
Thank you so much. I would love to divide our discussion to two main parts. The first part is please let us to know the most innovative approach for mental health. The second part would be what is the neuroscience of psychedelics and how they can be beneficial to the human mind.
Well, those are big and challenging questions, but let me start with the issue of innovation. The progress of neuroscience of understanding psychiatric disorders has really proceeded apace. We understand and have considerable data now about genetic risk profiles. We have incredible tools that can probe the brain and its networks and understand how brain connectivity, how the connections between different parts of the brain are influencing psychiatric disorders. We have tools that allow us to really study patients from the molecular and cellular level up to the network level. That said, the progress in therapeutics has not achieved all that we would hope at this point. We're still, as clinicians, using treatments that would be familiar to my colleagues when I started in this field 47 years ago, in terms of psychotherapies and targets of pharmacotherapies. There are novel approaches on the horizon and promising new approaches that are in development that involve interesting new targets for pharmacotherapy that are not the traditional monoamine targets. There is the increase in use of devices that have the ability to affect brain networks externally, variations on TMS, and even some promising new developments for deep TMS, or even very focused ultrasound treatments that may influence brain function and connectivity. So there are treatments on the horizon. There are some new molecular treatments that have shown promise. We've developed treatments for patients who have not responded to treatments before, so-called treatment-resistant depression. And I would suppose the most innovative example of that's in general use is the use of ketamine, which is historically an anesthetic and even has a history as a party drug, but has found its way as a therapeutic tool in treating patients who have not responded to other treatments. And ironically, it seems to work particularly well in those who are sickest and who have suicidal thinking. So ketamine treatment and the mechanism of action by which it works, which opens up new targets for treatment, is probably the greatest innovation. That said, the scale, as you reflected in your opening comments, of the need for treatment for behavioral health problems has expanded dramatically. The pandemic, and we can talk about this more if you wish, has increased the urgency and numbers of people with distress. Sure. Almost 100,000 people died by overdose in the United States last year. So even the availability of new medication treatments or new device treatments can't possibly meet the needs of the numbers of people who suffer, many of whom don't have access to care. So there's efforts to provide support through internet, through apps, through novel approaches to help a larger number of people through enhancing resilience and teaching basic principles of well-being, including exercise and diet and mindfulness or meditation, things like that, to try to increase people's ability to be resilient. That said, the challenges are still quite high, and I know we'll get to it later, which is why we're pursuing novel and innovative approaches that might surprise some of your listeners.
Yes, thank you so much, Dr. Rosenbaum. If you would like, we can start with pandemic and then go through psychedelics.
Okay, so in thinking about the pandemic and trying to understand why it's created such a pandemic of mental health distress, the data are quite clear. One of my colleagues at Mass General, Roy Perlis, has published some widely cited data about the increase in depression and anxiety during the pandemic. As I mentioned, the number of overdose deaths has increased. And so the first question is, before you can know what to do about it, I suppose you ought to try to understand why that's happened. And to be clear, there's no one answer. It's not simple. The pandemic brings to society and to humanity a number of different challenges, and everybody's different. And so the threat and the risk that the pandemic has brought for behavioral health problems will vary by situation. But let's just think about some of them. One of them is that people are trapped. They have not been able, until recently with vaccinations, been able to go out into the world, to be out in nature, to be out in the sun, to be many of them are trapped with people with whom they may have conflictual relationships that just increases the stress in families or relationships to be together all the time. And then by the same token, for some people, it's created isolation and loneliness, which is very toxic for humans. I mean, some people are comfortable more comfortable with isolation, those with social anxiety, for example. But most people will eventually find isolation, social isolation, quite stressful. The other thing is that it's a time of threat. I mean, the pandemic is literally life-threatening. And if you think by analogy to PTSD and what we've learned about PTSD, let's say in the military, you used to think about PTSD as a condition that arises from a single traumatic event, a dramatic event, a life-threatening event. But over time, as you study those who've returned from war zones, what you realize, many of those who suffer PTSD actually have never experienced a direct life-threatening experience, but they have been in a situation of abiding threat, of danger, of being in places where at any moment their lives could be at risk. So the term that's been used is deployment-related stress, not a single stressful event, but that over time, if you're in a threatening environment, it will have the same general effect on brain changes that are associated with PTSD as if you had a threat. And so if you're living in a pandemic where, there, particularly early on, people were disinfecting their groceries, terrified that they would touch something that would give them an illness they might not recover from. So people are in this state of constant fear, which creates brain changes. Your brain is a learning organ that adapts to the environment it's in. And if an environment is a threatening one, you become more vigilant, you become more anxious, you become more like people with PTSD. So that's another mechanism by which the pandemic has increased behavioral challenge. The other thing is that there are many groups in society who've been disproportionately affected by the pandemic. They've lost their jobs, they've lost their income, they're at risk of losing their homes, they have food insecurity, and so it's like suddenly finding yourself a refugee in your own land. You've left behind all the things that you valued and made you feel safe and happy and well. And then for those who already were, at the in a place in society where they had food insecurity and housing insecurity and poor access to health care and very little space in which to live, the pandemic simply amplified those challenges. So the pandemic is very much a driver of behavioral health problems. Now, we come into the world all somewhat different biologically, genetically, and some people are more resilient, some people are more vulnerable. And then what happens to us in life interacts with that resilience or vulnerability that we have. And so those who are more vulnerable, for whatever reason, are going to be, again, disproportionately affected by these challenges that I just outlined.
That's true. You beautifully analyzed the situation on employment, isolation, emotional stress. And as you beautifully mentioned, as an example, PTSD, as we go through post-pandemic period, possibly we will come across maybe a tsunami of depression and anxiety and other mental health issues. So it demands out-of-the-box thinking for innovative approach for treatment of different categories.
Unfortunately, the threats aren't ending. I mean, as you know, I think it's optimistic to say we're coming out of it. We certainly, those who have been vaccinated can feel more protected, at least against serious illness and death. But the more that this virus circulates in unvaccinated pools in the population, the more it can mutate. The more likely more infectious variants will continue to circulate. So I don't think in some ways we're ever going to be out of the woods in feeling entirely safe. The other issue is that we're facing other challenges. I mean, this isn't our only challenge right now. As as pessimistic as some people thought climate change predictions were. It turns out it's much worse than that. Things are accelerating much faster than even some of the more ominous models had predicted. You know, I remember being in the gym next to a guy, you know, during a heat wave a couple of years ago, and I said something about climate change, and he said, "I don't believe in climate change," like it's a faith, it's an issue of faith or something. And I said, "Unfortunately, the climate doesn't care what you think." And so we have other threats that are emerging. They're going to have behavioral health complications. We will have climate refugees, and we will have burdens that we'll face, and you know, and political upheaval and divisions among people. So you know, we're in a very ominous time in human history, and that won't help people recover from you know, this threat.
Thank you so much, Dr. Rosenbaum. As we can see in the next slide, MGH establishes new center to study psychedelic mental health treatment. Next slide, please. Next slide.
So, you know, I'm happy to talk about that while we wait for the slide to come up.
Yes.
That was from the Boston Globe, that headline and photograph from a few months ago. The fact that our department, or actually it's a multi-department center involving neurology, psychiatry, radiology, and now cardiology, in fact, came together to start a center to study psychedelic medicine. And I can tell you the story of how this came to be, and then talk about psychedelics. As a psychiatrist and a clinician interested in trying to find ways to help people that we've not been able to help well, I was struck by the importance of a cognitive phenomenon called rumination, that my patients who were suffering most and not getting better tended to ruminate a lot. Rumination is a form of stuck thinking, of dwelling on often self-disparaging thoughts or regrets, things that have happened. But unlike normal problem solving, and people don't move on from those thoughts, they go over, around and around, and stay stuck on them, and that creates a painful burden. And you see this in people who are depressed, you see it in people who are anxious, but then you see it in people with all psychiatric disorders, with people with substance use disorders, with addictions, people with eating disorders, with OCD, of course, that people, most of the burden of our illnesses are in this form of stuck, frozen, circular thinking about, again, problems, regrets, disparaging thoughts. And I thought that as a field, we had not really addressed those particularly well. Most of our diagnostic categories, you've heard of the DSM-5, which is the criteria for psychiatric disorders like depression, anxiety, and so forth. They don't talk about rumination. And yet this is what my patients were suffering. So in the latter days of my service as a psychiatrist in chief, I pulled together a task force to focus on that problem, and we began to pull together cognitive neuroscientists, neuroimagers, and others to think about how are we going to treat rumination better and maybe find a treatment that's transdiagnostic, works for many patients. Well, along the way, I went to a conference on psychedelics where a neuroscientist, psychiatrist from then at Imperial College London, now at University of California in San Francisco, named Robin Carhart Harris, was presenting his neuroimaging data. And what he showed was that when you look at the neuroimaging findings of people on psilocybin, you see this disconnection of a critical network in the brain called the default mode network, which happens to be hyperactive in people who ruminate. Now, a lot of other things were happening in the brain that was influenced by psychedelics, including new connections being made. But I was struck by this particular finding around the default mode network, which was relevant to rumination. So I decided to study I thought it'd be interesting to look at psilocybin in people who ruminate. Anyway, I'll make a long story short. And that led me into this world of psychedelic medicine, where I made contact originally with one of the founders of Compass Pathways, Katya Malaskaiva, who basically became kind of a muse and said, you know, can you think of something bigger than just studying rumination? And I said, you mean like study how psychedelics change the brain and the neuroscience of psychedelics? She said, well, you know, at Mass General, you have the world's best neuroimaging center, the world's best psychiatry department, or, you know, one of the top few anyway. And you could do this. You know, there at that moment, as you may know, there was a lot of commercial activity in the psychedelic space, but nobody had really taken on the challenge of understanding what's happening in the brain. And she thought we could do that. So she inspired the creation of the center, and through a foundation gave us some initial support, introduced us to some committed philanthropists, people committed to identifying new treatments for serious psychiatric disorders, and we created this center. And again, with the mission of understanding how psychedelics work. Now, for those of you who aren't familiar with what's happening in the world of psychedelic medicine and are surprised by this, let me first tell you what are some of the psychedelic drugs that are medicines that are out there. Well, you know, one of the most familiar is psilocybin, which is originally and continues to be found in certain mushrooms, although Compass Pathways company has found a way to synthesize as a medicine the actual chemical. So it's not actually from mushrooms, it's a synthetic compound like a drug, and has advanced that in a traditional drug development model through the various phases of drug development, and they're in late phase 2, which is doing the studies. And in fact, recently in the New England Journal of Medicine, a trial headed by Robin Carhart-Harris from London was published that showed that psilocybin was at least as effective as current antidepressants. And actually, if one looks at secondary analyses of other findings, arguably was more broadly effective for things you care about, like well-being and function, and not just symptoms. At the same time, there were other individuals who have held out for decades that there was something special in some of these other psychedelic medicines, like MDMA, also known as ecstasy, and LSD, and DMT, and 5-MeO-DMT, which DMT is the psychoactive compound in ayahuasca, and ibogaine. And so compounds like these that are from the natural world, which have been used in many societies, in many cultures, traditionally indigenous cultures, for thousands of years, for spiritual experiences as part of their culture, turn out to have profound effects on the brain that many people have felt could be exploited to treat mental illness. And in fact, going back to the 1960s, some of this work at Harvard, some of it in Washington National Institutes of Health, raised people's optimism that drugs, even like LSD, if used right, in the right context, in the right setting, could actually lead to cures or remission in some of the most devastating conditions, like alcoholism, like treatment-resistant depression. Unfortunately, there's a complicated story that this whole effort, the research effort, the serious research effort, went off the rails for lots of reasons, both cultural and political. And those drugs actually were banned from human use and human research for decades. But individuals like, in the case of MDMA, Rick Doblin, and others with other substances, sort of kept the faith that that there was something in these molecules that held promise for those who suffer. And so for decades they worked hard to prove this. And now, like MDMA, through the multidisciplinary association for MAPS anyway, the multidisciplinary association for psychedelic therapy, I think, or something like that, has actually created a not-profit company to develop MDMA as a treatment. And they've just published a phase 3 study of MDMA in PTSD that was a significant study that was published in Nature Medicine, one of science's most impressive journals. So these drugs are now emerging as having potential to treat people where other treatments have failed. Now, as you might expect, for better or worse, there's been a land rush of activity, a gold rush. Hundreds of companies have emerged to try to take advantage of this new enthusiasm that maybe there are molecules that won't just mitigate symptoms, but actually cure patients. And so there has been, I don't know, maybe something a little less than $1 billion of investment in commercializing various psychedelic. So we will see a future of psychedelic medicine. I don't know when. I mean, I think psilocybin and MDMA will have data sufficient to make them approvable by our FDA in 2 or 3 years. Whether they will be remains to be seen. But another important point is these medicines are not used like traditional drugs. It's not like an antidepressant. You take it, and if it works, you feel better. They're actually delivered in very specific sessions. So you might take it once or 3 times, and you do it with a therapist or 2 therapists, and actually in current case, who has prepared you for 8 hours, who has sat with you for 8 hours, and worked with you afterwards for 8 hours to integrate your experience. And that treatment is called psychedelic-assisted psychotherapy. And so far, what we've learned from that is that it works. There's more research to be done, and that actually corresponds to tens of millions of testimonials of individuals who have found their way to psychedelics one way or another, often in an underground or illegally, or gone to on trips to places where you can experience, an indigenous shaman, and many of these people say it's changed their lives. Now, I know some of these people, and I mean, from the outside, they look like the same people I knew before, but they describe feeling very different on the inside. And as a psychiatrist, that's all we can know. If you're feeling at peace where you felt anxiety, if you're feeling happy where you used to be depressed, I have to take that as an indicator that something has happened. And just this last week, there was a report, I think, from Yale looking at rat brains exposed to psilocybin, and lo and behold, there was impressive neuroplasticity, growth in dendritic spines and connections that were really unlike anything we've seen with other substances. So these medicines not only change networks, but they induce the brain to change through neuroplasticity, unlike anything we see in adult life. That's closest to things you'd see early in life, the ability of the brain to form new connections, to change its state. So there's stuff to learn here. Our center is simply focused on trying to understand what's happening in the brain. We're not involved in, proving that they work or the policy issues, but just want to do the neuroscience and know what's going on in the brain.
Impressive, phenomenal. As you mentioned, with current technology, the environment has enormously changed from, let's say, 1960 to right now, which is 2021. The sample size has been increased, and the technology and the rigorous control of protocols using these novel approaches at the right time with right dose will help us to avoid unintended consequences. I greatly appreciate this wonderful information.
Thank you. Yeah. Well, the unintended consequences still remains a concern because we know these drugs are effective in a setting where people are very carefully administered to. What we don't know is if they're widely available, will it be a net benefit for people or not? But I certainly don't think that anybody should be imprisoned for possessing them.
On top of all the things that you have orchestrated harmonious team, which is really wonderful.
Well, we have some great people at the institution, and I was just fortunate that the people I wanted to work with turned out to have interest in this area.
Again, so many thanks, Dr. Rosenbaum, for accepting our invitation, for your time, and the wonderful, wonderful information. Thank you so much.
Nagar, it was a pleasure to talk to you, and thank you for your questions.
Thank you so much.
Bye-bye.
Last slide, please. The last one. Yes. با سلام خدمت همه بینندگان عزیز تلویزیون جهانی کانال 1. همونطور که دیدین ما این سری آت آف د باکس بود برنامه رو از مهمون شروع کردیم به خاطر اینکه به زبان انگلیسی بود و به زبان فارسی ما در برنامه‌های آینده حتما برای شما ترجمه ورد بای وردش رو خواهیم گفت. خلاصه مطلب این بود که با توجه به پاندمیکی که ما در حال حاضر درش قرار داریم، منتال هلس اهمیت خیلی بالایی داره. آمار سویساید، خودکشی، دیپرشن، انگزایتی خیلی بالا رفته. CDC آمار رو منتشر کرده و ما امیدوار هستیم که بتونیم در برنامه‌های آینده مشاورا و صاحب نظرهای بیشتری رو در این زمینه داشته باشیم. یک سری حرکت‌های مهمی در این زمینه انجام گرفته، چون پاندمیک و پست پاندمیک، آیسولیشن، آن ایمپلویمنت، ایموشنال استرس، همه اینا مردم رو خیلی مستعد کرده بیشتر برای منتال هلث ایشوز مثل دیپرشن، انگزایتی و آمار سوساید در کالج استودنتس، در رده های مختلف اجتماعی. یک سری اپروچ های جدیدی در دانشگاه های مختلف من جمله هاروارد انجام شده که استفاده از یک سری سابستنس های طبیعی در یک سری دوزهای محدود تحت کنترل، تحت آزمایش هست که ببینن برای کسایی که به درمان مقاومن آیا تحقیقات نشون خواهد داد که اینها افکتیو هست یا نه، که ما امیدواریم حتما آپدیت ترین تحقیقات رو در برنامه‌های آینده خدمت شما ارائه بکنیم. خیلی ممنون که بیننده برنامه ما بودیم. برنامه ما هر هفته سه‌شنبه ساعت 6 بعد از ظهر به وقت غرب آمریکا مطابق با 5:30 صبح به وقت ایران پخش میشه و ما جدیدترین و تازه ترین یافته های پزشکی و اطلاعات پزشکی رو خدمت شما ارائه خواهیم کرد. تا برنامه بعدی، روز و روزگار خوش.